Good evening, everyone. Thanks so much for joining us this evening for NAMI Prince George's Annual Education Forum. NAMI Prince George's is dedicating to building better lives for persons with mental illness and their families who reside in Prince George's County. We believe that the county must have access to an effective and appropriate crisis response system for children and adolescents with mental illness. My name is James Freeney. I have the distinct pleasure of being your moderator this evening. I have the privilege of being a NAMI member, supporter, volunteer, serving on the board of directors, and as a NAMI Prince George's County facilitator for a NAMI Connections recovery support group for individuals living with mental illness. For my day job, over the last 12 years, I've served as a director of operations for DC Coalition for the Homeless. Our theme this year is advocating for change, dignity, compassion, and hope in Prince George's County crisis response services. NAMI is committed to advancing efforts to reimagine crisis response in Prince George's County. We are calling for a standard of care that provides a continuum of crisis services that in the revolving door of the emergency room visits, arrest, incarceration, and homelessness. We believe that every person in crisis and their families should receive a humane response that treats them with dignity and connects them to appropriate and timely care. We hope that you will learn something this evening to help you to be a better advocate for yourself as a consumer of behavioral health services or for a loved one living with mental illness. I'd now like to welcome our presenters for today's workshop, Deborah Bennett and Margaret Fowler. Deborah Bennett has been actively engaged as a NAMI Prince George's member, volunteer, employee, and consultant over the last 9 years. In December 2021, she began serving her second time as a family peer support specialist, supporting county families, caregivers who have 16 to 21 transition age youth and behavioral health needs. From 2019 through 2020, she initially served as NAMI Prince George's County First Family Peer Support Specialist. In her role as a family peer support specialist, Deborah provides community leadership, supporting the county's efforts to improve its system of care for transition age youth to establish collaborative partnerships with other organizations serving transition age youth, serves on the county's local care team that identifies community mental health and other resources for families, helps families to navigate the behavioral health care and other organization systems, and empowers families with hope through mental health education and support to advocate on their own behalf. Margaret Fowler is currently serving as Executive Director for Totally Linking Care, Maryland. Totally Linking Care, Maryland is a nonprofit coalition of 6 hospitals that connects healthcare providers from programs with Southern Maryland, including Calvert County, Charles County, Prince George's County, and St. Mary's County. Totally Linking Care, Maryland believes that everyone deserves access to quality healthcare. The organization builds innovative health programs through grant funding and sustains them through public-private partnerships. Margaret is overseeing a Health Services Cost Review Commission Regional Partnership Catalyst Grant Program that supports the implementation and expansion of behavioral health crisis management models that improve access to crisis intervention, stabilization, and treatment referral programs to Prince George's County. Thank you both so much for joining us today. We will be addressing questions at the conclusion of both presentations. If you have any questions as presentations are being made, please post your questions in the chat. We will be reviewing questions as they come in, and if it's something unclear and needs to be expanded, we will ask our presenters after the presentation has concluded. If you have any comments, concerns, or technical issues, please post them to our chat, and our technical assistant will address them accordingly. Deborah, as a family member of a loved one living with mental illness, will you please share with us your family's experience navigating the mental health crisis system and speak on your advocacy efforts to affect change in this area?
Yes, thank you, Jamie. I would like to do it by presentation, but the why is, why am I able to speak to this in terms of navigating a crisis? And it's because, unfortunately, since COVID and prior to COVID, I've had to navigate over 20 crises with my son, who is my loved one, in multiple counties in the state of Maryland. And so having gone through that, I have had to use the resources that I'll talk about that NAMI has provided. I've also had to advocate, and I realized I was doing personal advocacy, public, as well as legislative, because I want my loved one to live a life, and I love the title that we have, a life of dignity. I don't feel that's occurring right now because I have identified several gaps in terms of outpatient services, and one of them is one that I will talk a little bit more about, just to kind of whet your appetite and educate you. And I think it would be one that could help him to live a life of dignity. And so if you're ready to show the presentation, next slide. So again, NAMI has lots of resources, and they are available through internet searches on NAMI National's website. And I've had to use those resources serving as a family peer support specialist when I didn't know that that was a title, and I was doing it on behalf of my loved one, but also in my current position. And so what I'd like to do is to give you an overview of the 18-page guide, and hopefully you'll look at it later in terms of seeing what the resources are in there, and then some suggested resources based on those different areas. And then I also would like to talk about a treatment gap. And part of managing a crisis is advocating. And it's one that we do not have in the state of Maryland. It's referred to as assisted outpatient treatment, which I feel personally would be a treatment that would, a tool that will help my son to remain in the community and live in dignity. Next slide. So this is what it looks like. It is a wealth of information, and like any other health crisis, it's important to manage it quickly and effectively. So the guide gives you different strategies on doing that. Next slide. And these are the different areas that are covered. Understanding a mental illness. And I'll share with you in the next slide some of the resources that NAMI offers and others in terms of how can you get an understanding about mental illnesses. And then how do you manage your crisis? What can you expect in a crisis? How do you advocate for treatment? Because we're doing that all the time, from the time that we notice that there are some changes in our loved ones' behavior to how do we get them into a hospital to be evaluated? And then what happens once they're in there? And then when they come out, my son over the last 2 years, that's when decompensation begins again, because now he's out of the hospital. And I'll talk about some of the other types of crises, which I've had to unfortunately navigate. Missing loved one, he's been missing. He's also recently been arrested, and he is currently now in a state hospital as a result of having been arrested because he was determined to be incompetent to stand trial. And then preparing for a crisis. Again, NAMI has some fact sheets that talk about how to use it, that notice the signs and the symptoms. What if suicide is, something that is possibly a consideration or being discussed. And then there are other tools like what do you do to prepare? And the best time to prepare for a crisis is, guess what? When you're not in crisis. And so we can go to the next slide. And as I share a little bit about my son's story or his crises over the last 2 years in my family's, I'll share with you how I've used these resources. I know this is probably small print, but with mental illnesses, there's often co-occurring condition, dual diagnosis, meaning that substance is used. And oftentimes our family members are using substance to self-medicate. Instead of taking a prescribed medicine, they're using substance. And so you can find out about the different conditions on NAMI's website. There is a website that has the different conditions. It'll tell you signs and symptoms. It talks about medications, things of that nature. There are also infographics. And then we have classes. We have the NAMI Family to Family. We have NAMI Family and Friends. There's peer-to-peer. So these are the different types of classes, seminars, and presentations that are available through NAMI that are free. Did I say free? And they are done by volunteers. And so the volunteers for NAMI is the blood of the organization. So when you take one of these classes, trust me, you're going to want to get trained, and then you're going to want to give back because you get so much out of it. And that's how I actually became connected with NAMI. I was searching on the internet. My son was diagnosed with psychosis not otherwise specified. I'm like, what in the world is that? And so I did a Google search, and then I found NAMI, and I found out that they had the family training. And as a result of that, I said, I need to take this training. It was being offered in Anne Arundel County and Charles County. So I registered for both. I said, I'm going to try one class and one another. So I went to Charles County, and as a result of that, I took the class, and then I eventually ended up meeting other residents from Prince George's County and being involved with the board. And so that's how I got connected from that one class. And it's been now 10 years as a NAMI member. Understanding the mental health crises, there are stressors that happen that we need to, understand. There are warning signs. And the resources that you can use to find out about what are the stressors. You can use the guide, but there's also the NAMI website, and then the infographics and the classes that I mentioned. We talk about some of these things. What are you doing in mental health crisis? There are crisis numbers now. Specifically, NAMI advocated to get the 988, and then we have the 911. And when you call 911, ask for a crisis intervention officer, CIT. That means that they are trained to engage with individuals who are in a mental health crisis. And again, we have the crisis lines and their crisis text now. So there are many different ways to indicate that you're in a crisis and to get some feedback on what to expect from a mental health crisis when your loved one is in the hospital. Confidentiality, unless you have your loved one signs a release of information, or if you do not have guardianship, oftentimes, typically the staff will not talk to you. I would say I have been very fortunate that the staff have been willing, once they know that you are a family member who does care, and this is my own personal experience, I have been told things directly, I encode, and then emailing. But I also have a Maryland Advance Directive. And that is important because I'm able to request HIPAA medical information on behalf of my son. When he's in the hospital, I can request that information. And it's important because you want to start documenting when they were in the hospital, what medications were they taking, what is the diagnosis. And so that's something that I use in a portable treatment record template. And that is a template that NAMI provides, and that's one of the tools. So I keep that updated, and it has been beneficial because when I had to file an emergency petition, which the form is online, I fill it out online, and I'm able to attach to it the chronology of my son's hospitalizations. And when I'm in the courtroom, one of the judges made a comment, I really appreciate the way you have chronologized this information because it's very helpful. And my response to him was, thank you, I'm a NAMI mommy. And so that wasn't the first time. When my son was also in the emergency room, what I do is when I know he's in the emergency room, I'm reaching out, I'm trying to get a contact. I want a fax number, I want a name. I'm going to fax you this chronology of his most recent hospitalizations. And someone in the ER, the doctor who was evaluated, made the same comment. I appreciate you doing this. Now I do not have to go into our system and find out which hospitals he's been in or how many times he's been hospitalized. So that has been a very important document for me. And again, you can get some of the same information from the classes that we offer, the seminars, and then the website. Advocating for treatment, which I'm going to talk more about, is part of navigating a crisis, because you're advocating when your loved one goes in the ER. They really need to be there because this is his 15th hospitalization. Can you please evaluate him, hold him for 72 hours. Once he goes into the inpatient, I'm advocating there. Can he stay longer than 2 days? Things of that nature. Is there going to be a hearing with the administrative law judge? If so, can you please let me know, because I would like to participate in that meeting and share what's going on with my loved one. And so that is part of advocacy. What medication are they on? Why did they switch the medications? And things of that nature. So it's very important. And having gone through this over almost 20 times in the last 3 years, I have identified a gap. And I'll talk more about that. But again, if you are navigating so much, you will sometimes find that your loved one is not getting fair treatment. And so you need to know what you can do, who you can talk to, and who you can write to, because I have written to the governor, I have written to the CEO of Shepherd Pratt, I have written to the head of the Maryland Department of Health, because email is so easy to get and it's so quick to send information. But the point is that these are our loved ones, and it is a condition as well as other somatic. And I think that our loved ones deserve fair treatment and treatment with dignity, but there are gaps in terms of how our loved ones are treated. In addition, everything in Maryland is voluntary. Everything is voluntary. So that means that our loved ones can continue to cycle from the ER to the inpatient, outpatient, shelters, homelessness, incarceration, and it continues. And as part of that, they oftentimes are missing. Some of the tools I've used is missing persons report. I've had contacts with individuals. My son is missing. Can I send you a picture of to the different shelters? Can I send you a picture? Can I send you information? Because maybe they've gone there. And there are connections that you can make, and people are willing to help in Prince George's County and Washington, D.C. My loved one might be in a shelter. Can I send you information? They will check. I have done it for parents, and I didn't, have a document, but they will say, no, this person has not been here. Yes, they have. And so it's just a matter of people feeling that you're compassionate and that you are really concerned about your loved one. So that requires advocacy. And advocacy, again, is in 3 different ways. It's in your personal, it's in the public, and it's in legislation. And preparing for a crisis, again, the best time to prepare for a crisis is when you're not in one. And I had mentioned this to my son about 2 years ago, pre-COVID, after he had had one hospitalization. I said, we need to do a crisis plan. He kind of looked at me really odd. Now, my son doesn't live in Prince George's County. He lives in another county. But because I'm navigating across counties, I knew that we needed to have a plan, but we just didn't get a chance to do the plan. And so with the plan, he would have had input into what does he want? What does he prefer? Which hospitals, what medications? But we didn't get a chance to have that conversation. And so as a result, it's just something we didn't get to do. But as I did mention, I do have a Maryland Advanced Directive. And so that does give me a right to get medical information about him. I see a lot of his discharge papers, the hospitalization papers said that he doesn't have one, but finally, when I sent it to one hospital in Baltimore County, I do see a yes on there now, because they do offer it, but he didn't know if he had it. And of course, they didn't know. So I'm faxing those documents to them. Email and fax, your best buddies. People, they're willing to receive information, because one thing we need to know is we can tell the therapists, we can tell the doctors any and everything we want them to know about our loved one. While they are not able to share that information with us, we can tell them. And oftentimes it fills a gap because our loved ones are not in a position to have that conversation. And so again, the NAMI resources, there are many. You have the classes, the seminars, the presentations, the infographic, the fact sheets, and the portable treatment record. That is one that's also available on the website and in the fact sheets. Next slide. So as I mentioned, I found myself doing more advocacy over the last, I would say 9 months. And I was sharing with JB about 2 years ago, I did a vision board, and NAMI's newsletter is called The Advocate. So I was cutting out words and I put advocate on it. And fast forward a year, 2021, I've had to do quite a bit of advocacy, actually starting last year, because my son was having so many hospitalizations. It was one thing after another. And after I realized all these hospitalizations, all of the resources that he's been able to be afforded on a voluntary basis, residential rehab programs, crisis stabilization. He's had more residential rehab programs. He's been in shelters. And all of these things are voluntary. He goes in the hospital, he gets stable. 3 or 4 weeks later, he's been in hospitals at least 5 weeks. He comes out because, again, he's stable. And then yet the circle starts all over again. There is nothing that assists in a required manner when they are discharged from the hospital. So his decompensation starts the day he walks out of the hospital. And as I mentioned before, he is now in a state hospital, a state psychiatric hospital in Maryland, because he was trespassing. Why was he trespassing? Because he walked away from a crisis residential house that was voluntary. He's in a community because he has a right to be in there unstable and unhome. He is now without a home. Why is he end up without a home? Because he was unstable. He lost his apartment a year ago. His voucher is now impacted. He's in jeopardy of losing the voucher. But I was able to get it extended for almost a year as a reasonable accommodation, from one county to another county to another county, back to another county. And it's been extended. People have been gracious and understanding, but he's not in a position to benefit from these different opportunities. He walked away from a residential crisis program after 3 months. Well, I'll just be homeless, because he lacks insight. He wants what he wants when he wants it, and he lacks the insight. So guess what? He gets the opportunity to keep doing that. But each time he has a crisis, he is decompensating further, and his brain is being impacted more. So I've had to do 3 types of advocacy. I'm educating myself on these different processes. Now my son is incarcerated. I knew about the mental health court, which is a problem-solving court, because I recommended it for him when he lived in Prince George's County. And shortly after that, he moved to Frederick, but he completed it within a matter of 4 months. Again, that's voluntary, but it was with the support of the mental health provider in Frederick, me as a NAMI mommy, and then his mental health provider that was here in Prince George's County, who first recommended him for that. So he completed that. I've had to normalize the conversation, and that helps to reduce stigma by having conversations publicly, like what I'm doing now, and just talking to other people in different venues. I am pretty transparent about what I've gone through, because I feel like it's for a greater good. And so as the legislative component of it, once I found out about the assisted outpatient treatment, I was looking for something. What can help my son to stay stabilized in the community? He is an adult, and it's very hard for me to get a guardianship for him. I've kind of looked at that over the last 5 years. So as a result of that, I just, found AOT. And so I started reaching out to get more information about it. My voice, I wanted it to be heard. So as a result, I started advocating early this year, because there was a Maryland bill, both a Senate and a delegate bill, that was proposed for Frederick to have a pallet. My son was no longer living in Frederick, but it didn't matter. If we could just get one in the state of Maryland, we possibly could see how it worked. And it's not a panacea for everyone, but it is a tool that doesn't exist right now. And so as a result of that, I did speak to different senators, delegates, and let my voice be heard. So again, that's the advocacy, and that's the gap. Next slide. So why do I advocate? Our topic says it. I have hope and compassion, and I want my loved one to live a life of dignity. It's for change. And I found this, I was doing some searching again. It's just, I'm just a mom advocating for my son with as much passion as I can muster. And this came from another mother, not alone, NAMI.org. And so that kind of speaks to me in terms of what I've been engaged in the last year, more so in the legislative advocacy. Next slide. And so a little about assisted outpatient treatment, which is better known as AOT. SAMHSA offers grants for this program, and it's been around since 2014. And it is a tool in a toolbox. It's not a panacea. It's a civil outpatient commitment that will require my son to stay on his medication. It's not forced treatment, it's not forced medication, but he would be required to stay on medication. If he was not, and he was in a community imbalance, I could call and tell his mental health provider to say, my son is, not on his medicine, he needs to be evaluated, versus me having to go to a different county, do an emergency petition for him to go back into the hospital. And it benefits him because he would stay engaged in treatment. And that's what I want for my son. And that's what he wants for himself, but he lacks the insight to do that. He lacks the insight, he feels like he can medicate himself with substance. He just doesn't have the wherewithal right now to do what he needs to do. But his goals have not changed over the years. He wants his own place, he wants a wife, he wants a family, he wants a job. They have been consistent, but with his inability to be medication compliant, that has been a challenge the last 2 years. And so the AOT, it aims to motivate and assist individuals with severe mental illness, as my son has schizoaffective disorder, to engage in treatment and to ensure that the mental health system is attentive to their needs. So that's one of the benefits of AOT. Next slide. And this is how it works. It will be a court order from a judge upon discharge from a hospital or the jail for them to, for individuals who are in community who are cycling. If they're in a community cycling, or if they're coming from jail or hospital, they could be put on an AOT. They will be involved in developing their treatment plan. And so it's not something that's forced, you will do this, you will get a long-term injection. They are included in developing their collaborative treatment plan. The plan is monitored by their local mental health provider who's part of the system. And if my son, say for instance, was on an AOT, was not on his medication, they could take him to the ER in order for him to get an emergency evaluation, versus me, the caregiver, who oftentimes is now a big gap in our relationship because I'm having to do it more often than not. And then if he's not complying with the treatment, the plan could be modified. There's a gentleman in Texas who said that the medication he was on, he didn't like the side effects. So the judge and his mental health provider, they changed the medication. He had some input into his treatment plan, or they could be ordered to go back to court. With the mental health court, they are required to go, to hearings frequently. My son had to go at least once a month when he was in mental health court. And then evaluation, that's what I talked about, whether or not they need to be hospitalized to get stabilized. And if they participate for the year, the orders are typically a year, the court can dismiss the AOT, and then, or either they just allow it to expire. But the goal of it is to help the individuals who are, some percentage of them who are unable to stay compliant in the community to engage in their treatment. And so once they engage, then they, become more compliant. Next slide. And, is it effective? Of the 47 states that do have it, they say that there are, it is effective. And these are some of the benefits. It improves treatment outcomes, substantially reduces the repeat hospitalizations. Check, my son has done that. Reduce criminal justice involvement. Check, that's now, part of his record. It also shows reduced hospitalizations. He's had 20 over the last year. Length of hospital stays, he's probably been in one hospital maybe 45 days, but that was due to advocacy. Incidents of arrest are reduced and incarceration rates are reduced. These are not things that I wanted for my son, and these are not things that he wanted for himself. But with the lack of insight and his ability to stay the course on medication and compliance, this is what has occurred. Next slide. And again, homeless nights. He has stayed in shelters, but because of his behavior, he was told he could not come back to a shelter. So when you can't go to a shelter, where do you go? Violent behavior. One of his most recent hospitalizations, he did have some wounds on his body. Where did they come from? You know, you're out in the street. So he has been a victim. He is not, sometimes his behavior could look violent to other people because of, you know, the behavior that he's exhibiting. And then there's significant cost savings. Well, cost savings, I won't say significant, but they are. Because he's been hospitalized, the cost has probably been probably $300,000 now as a result of that. So he's a high inpatient utilizer of services. And again, the gap is, and the increased result is that participant satisfaction. Those who participate in the AOT, they're satisfied. Next slide. So again, it's a gap. Maryland is one of 3 states that does not have a AOT yet. And I'm just going to speak, you know, in the positive, because I'm going to do my part in trying to, you know, explain how I see it as a benefit to certain individuals and loved ones. And in order to, for us to get it, we have to advocate for change. And this was something that I saw. It is something that I feel is going to be beneficial to my loved one and to others who have loved ones who are just unable to stay compliant in the community. And again, it's not a panacea, and you know, everybody doesn't agree on it, but this is something that I feel would be beneficial to my son after the last 2 years. It's a lot on him. I'm not living that life, but I'm living part of the life because I am his caregiver and his family member. So again, this is something that I see as a gap treatment. We do not have any, we have a lot of voluntary programs. They can agree to participate or not. We do not have anything that's going to help them to remain compliant in the community. And so AOT is something that I am supporting. Next slide. So these are some crisis contacts in Prince George's County. And this, iMind is our new behavioral health crisis provider, as well as the mobile crisis. They provide the services. So this information is available on, I'm sure, our websites and on NAMI's website. So I hope this has been beneficial to you, me sharing my personal story and why I advocate and what gap I have identified that I can get behind and will hopefully help some other families. So again, thank you for hearing my story. And if there are questions, please put them in the chat.
Thank you, Deborah. You know, you always strike me as an amazing woman and advocate. And I've told you before that I'm very impressed with your knowledge. It's almost like you've worked in the field yourself for many, many years. I have a quick question for you. In your view, you mentioned a few times during your presentation the lack of the fact that many services were voluntary in Maryland, and you seem to emphasize that and perhaps even see that as a negative. Can you, at least in your view, tell us why you think that is?
Yes, let me clarify. I don't see it as a negative because I think people need to have choices, but everything we have in Maryland is voluntary. We don't have civil commitment. And what struck me even more so was yesterday, I got an opportunity to speak with the psychiatrist at the state hospital. She was willing, I sent probably every medical documentation I had on my son. You know, one thing I started doing was when he gets discharged, I'm getting his medical information. She looked over all of it and she basically said, he has been stabilized before. I cannot civilly commit him. He has been detained in the state hospital almost 90 days now. So when he goes back to court in November for his hearing, he is probably going to be released. So here we go again. You're in a state hospital because you were incompetent to stand trial. Now you have served your 90 days because it's a misdemeanor it's a misdemeanor, it's trespassing. And when you go back to court again, they could say, okay, you served time, so now we're going to discharge you from the court. Where does he go? So do we start all over again? You were in a state hospital, but you don't meet the criteria any longer to stay there. So you're going to, and he could possibly just say, okay, I'll just walk away from the court, or he can voluntarily agree to go back to the state hospital and work with them while they look for placement. But once he voluntarily agrees to stay in the hospital, within 72 hours, he can say, I'm going to leave. And this is what happens the majority of the time. He is not civilly committed in the hospital because within a certain time frame, he understands enough to say, you know what, I'm going to voluntarily stay here. And then he knows 72 hours after that, I can leave. And so he's been willing to leave homeless. He's been willing to participate in programs like Go to a Residential Rehab program. And all of these programs, the crisis house, the residential rehab, they require them to be interviewed. They have to do an assessment. You know, are you willing to do A, B, C, D, F, G? And you may say, yes, I am willing to do A, B, C, D, F, G. And they can say, well, you know what? I will accept you into my program, my crisis house, or I will not. So that's all voluntary. Or, and if they do, they can voluntarily walk away, which he has walked away from crisis houses. He's walked away from residential rehab programs. And these are all services that were available to him. But there's nothing to civilly commit him. And that's what the doctor said yesterday. Well, we don't have a outpatient civil commitment in Maryland. I said, I know. And as a result, it's like, what do you do? We just hope that he agrees to voluntarily come back and stay until we can get him placement. So that's why I made the emphasis on voluntary versus the, you know, the civil commitment. We just don't have that.
Okay, well, thank you for that.
You're welcome. Thank you for asking.
Yeah. So Margaret, so what we're looking at is that it is well established that at this moment in Prince George's County, that behavioral health care is limited. Will you please share with us the behavioral health care crisis response system being developed and implemented in Prince George's County?
Yes, thank you very much, Jamie. I'll be happy to do that. And I just want to, Christina, if you could just put the slides up, that would be wonderful. Thank you. As we get started, I just wanted to say thank you so much for allowing me to speak with you tonight and share what we are doing with the Regional Behavioral Health Catalyst Grant and hoping to help make a difference, you know, in Prince George's County. Just a little bit, I've been with TLC for about 1.5 years. And prior to that, I've had about 20 years experience in various hospital systems, developing strategies and community-based programs that meet the needs of the community health needs assessment. And then I started off at TLC basically as a project manager for another grant. And then in June of this year, I was blessed and honored to be chosen as the executive director and lead this project. And it has been so important to me because like Deborah, you know, I too have had some family members that have been in a very similar situation. And I hope what we're developing can help get the resources in at least Prince George's County. So I'd like to share with you the components of this grant and progress that has been made through the dedication of many people and a lot of teamwork. So if you could go to the next slide, please. This slide here is just basically sharing with you the 5 components of the grant. We have air traffic control software, a 24/7 mobile response team, 911 to 988 integration. We have a readmission reduction program, and then we have a receiving and stabilization center. And the upcoming slides, I'll go over each one of these a little more in detail. The next slide, please. The air traffic control software, Behavioral Health Link, is a software system that's being piloted actually by regional behavioral health grants through the state of Maryland, and also is offered in other states. GBRICS in Baltimore has the entire suite of modules. However, here in Prince George's County, we only piloted the mobile response team module and integrating it with the existing call center who's been serving Prince George's County for years. We're working with them to integrate this dispatch system for the mobile response team. What they do is it allows us to centralize all of our data. What happens is 988 will do a warm transfer to the mobile dispatch. The mobile dispatch will then connect the mobile response teams. They are available 24/7, 365 days. And as of today, there are 6 mobile response teams in Prince George's County. Part of our goal with the TLC was to expand, which I'll talk a little bit more about that. And we have now succeeded by getting 6 teams. It was the behavioral health link software. It went full operational on just October 10th of this year. And so far in 16 days, it's already received 145 calls. What was really nice about this is that it allows us, like I said, to integrate data collection, and it gives us an opportunity to be able to locate where the teams are at any given time. It will let us know what team is closest to the next call that's coming in, and also which teams are available and which teams are not. And then most importantly, it gives us a lot of data that we can strategically plan moving forward. So you can go to the next slide, please. The next component is our mobile response team expansion. As I mentioned earlier, we wanted to increase the mobile response teams by 4 and have a total of 6 teams. And I'm so happy to say, because we were up, we had 3, then 4, but I just got a text that said basically we are now up to 6 teams. There's 2 in the morning, 3 in the afternoon, and we have 1 overnight. We did transition and we tried to consolidate our mobile response team under one entity for Prince George's County for continuity of care and a seamless and unified process. We're working with the state now too to also help align services so that they can meet the mobile response team guidelines for reimbursement. And once those regulations are coming out, it should be, I believe, it's either June or July of 2023, which will help sustain some of these mobile response teams and not depend just on grant funding. And I wanted to say, you know, under the hard work and dedication of CCSI and iMind, they've built a lot of the foundation that the mobile response team program has done over the last year. So I'm just so proud of what they've done. They're seeing over, like I said, last month, they had over 124 calls. And now since 988 has gone live, you know, you can see the numbers have even gone up. What we were able to do was also, they used to have the Sante number, that we were able to get that back as well. And we have found that there's been a high number of calls that are also still being called. And so now we have captured that group as well. So it's been really, really wonderful. We have also are working with care coordination within the crisis services. We are linking the mobile response team to individuals in the hospital, which I'll talk about a little bit later, that then we can decide what level of care is most appropriate for those individuals if they are taken to the hospital. And as Deborah was saying, you know, you go into the hospital and sometimes it's voluntary, you just walk out, and then the next day you're back and you're doing the cycle all over again. We are working to help make sure that they get navigated to the appropriate level of care. And I'll talk about one of those in the slides further down. And then what we're also doing is developing mobile response team education materials, you know, for the community and the provider, so that they know when we're building these teams and other programs within the crisis system, they'll know how they all interact together and are coordinating. Next slide, please. The other part that went live on October 10th was the 911-988 behavioral health integration pilot. The goal of this was again to increase rapid access for the care of people in mental health distress, and then lower the involvement of police with the low-level calls. There has been a tremendous amount of work that's been gone into this. And I'd like to acknowledge that, you know, with the leadership of Dan Cornfield from Dignity Best Practices, he was one of the TLC partners that was leading this initiative and developing all the training materials and coordinating many, many meetings. I have been in meetings, we're meeting sometimes twice a day with the work group, with leaders, trying to iron out anything that comes up. It's just like anything that you start and you try to implement, you have to address any little hiccups right away. And with so many agencies, police, fire, EMS, health department, you know, health providers, hospitals, it has been an amazing process to see the collaboration and the coordination of all of these agencies working together. And that's what we need to do as a community. Everyone needs to be involved in part of the solution. And to date, we haven't had 11 calls have been transferred. So, and you know, we're still working out those kinks, but you know, it is working, and we're building those relationships with the mobile response team and with police, fire, and EMS. You want to go to the next slide, please? The next component of the grant is called Mindula. It's an intensive 32-day care plan to reduce the use of the ED and for readmissions. They have dedicated care coordinators at both UM Capital Region and MedStar Southern Maryland Hospital. And so they try to make sure that they work with individuals that have had, you know, an ED visit or multiple ED visits, that again, they have them transferred to their care where they do an intensive 32-day treatment. And also for people that may have had a medical issue, but also mental health issues or substance abuse issues, they will also be working with those. But we're trying to work within the hospital systems to, again, it's like connecting the dots and letting everybody know who is there and where is the most appropriate referral source at that right time, right place. So I'd like to share some of the outcomes from Mindula. So if you can go to the next slide, please. So the readmission reduction program right now with this grant, it involves Adventist Healthcare, Fort Washington, University of Maryland, Laurel Regional Hospital, University of Maryland Capital Region, and University and MedStar Southern. And to date, they basically have had a reduction, or they've served about 513 from January to August. We have not gotten the stats for September and October. What we do is we have 69 allocations across those 5 hospitals, and anyone that is in the ED for frequent flyers and or high acuity and they're discharged, they can be eligible for this program. The care coordinator in the hospital has to make the referral to Mindula. They're also available to those individuals that are going to be discharged from the hospital. And they can also do a 32-day comprehensive follow-up plan, but they need to be referred while they're in the hospital. They can't be referred once they're out of the hospital. And then in calendar year 22, this year through May, there's been a 43% reduction in the 30-day readmission after inpatient psychiatric or ED discharges for the member hospitals that I mentioned to you. And right now we're evaluating integration with the mobile response team and the crisis stabilization center that is also part of this crisis continuum. And hopefully that will be opening up in the late spring. And you can go to the next slide, please. And the last component of the grant is a stabilization center. It is going to be located in Southern Maryland in Clinton, right off of Route 5. It's the Dyer Building, and it's going to be a 16-chair facility. It's a 23-hour observation and stabilization center, and they have the no wrong door policy where you can do walk-in. There can also be police escort, and we're also integrating the mobile response team. So this will be a place that they can go instead of the emergency room if it warrants that, and they meet criteria. And they will have coordinated care here before they're released. The goal is to, again, connect them with resources before they leave. You can go to the next slide. The next slide I wanted to share with you is actually just a glimpse of what it's going to look like. It's going to be on the second floor of the Dyer Building, and the way the topography of that facility is you can access the first or the second floor right from the parking lot. It's going to have a nice welcoming awning. You can see that right at the beginning, they call it a sally port. If you can look at the, I guess if you're looking at the blue section, the corner all the way to the right, it's like has all the doors that open. That's called the sally port. That's where police will be bringing patients. And then they have right now, they're thinking of, they're going to have in other counties, it's like a 5-minute turnaround time where they intake the patient and the police officer can get back into his duty. So again, the goal of this center is to reduce the hours that police have to take to the ER or wait. So we're really excited about getting this done. It is now, the building is completely empty as of today. I think it was the last day. We've already done a walkthrough. There are permitting that's going on, and the schematic drawings have been submitted. So now if you want to go to the, this is going to be, you can see the 16 chairs they're in groups of 4. There's a nurses station that will be, they can see all of the participants when they're there. And there is like a little eating area as well. And there are rooms for seclusion if that needs to happen. Right now in the state of Maryland, there are not regs for this facility to be able to function as a 23-hour stabilization center where they have medications that can help. So they're waiting for those regs to be published. TLC is working with the Behavioral Health Authority at the state level, as well as working with the state and COMAR regs to ensure that as we're building this with all of the programs we're building, we're trying to make sure they're aligning with all of the state regs so that these programs can be sustainable and get reimbursement. Right now, we're looking at Medicare and Medicaid covering the services. And they're also, through the federal government, there should be parity, which means that other private pay will also have to build in and pay for crisis services. So we're not only building the facility, but we're also working with trying to help the state develop COMAR regs and rates and codes for reimbursement for sustainability. And you can go to the next slide, please. I just wanted to share with you here sort of what other centers look like around the country. We are working with RI International. They are the operators that will be working with us. The grant is paying for the full build out of the center, remodeling everything on the Dyer Building, as well as the operating cost. And then there will be a cost sharing, and we'll be looking for additional funding for fiscal year 25 to help offset the cost of operating. But our goal here is through reimbursement, through Medicare, Medicaid, and private pay and commercial insurances, that we will reduce the need for gap funding from the county, but we're also thinking, there's a lot of federal grants, state grants, and county grants that will help support this system. And you can see this is a much nicer venue to spend 23 hours while they need to calm down or be stabilized than an ER room or in a room that basically you have everything taken from you and you're in there all by yourself. You can't go to the bathroom. This is a much more relaxed environment. So what you had talked about and what Deborah was saying about dignity, that's what we want, to have in this facility, that it will be a place that they can be comforted and get the help that they need in a very warm and inviting environment. Can you go to the next slide, please? Wanted to share with you, this is sort of the proposed community engagement activity. We have been working with all of the hospitals, all the necessary county departments, the marketing teams, to make sure that we're engaging with the community, letting them know all the way what's happening at every step. So we are now developing a logo for the center, as well as trying to come up with 3 to 5 names. And right now what we're going to do is, when they engage the community, is allow them to possibly select the name. So we want, again, the community, this is for the community to own. And so everybody that can be engaged, and everybody here, let's all figure out, how do we support this? How can we help NAMI make sure that we coordinate things that in the center that has all the information, and that we share in building this crisis continuum. So we will keep you updated on everything that's going on. It will be going out not only on the TLC website, that's the other thing I didn't mention. It's not really part of a component, but I think it's going to be really important as far as communication is concerned. The TLC website has been totally revamped to be a direct-to-consumer website. It is focusing right now on chronic disease management and diabetes, but we will be developing an entire behavioral health web pages for each of these components of the grant, and having all kinds of resources, social media outreach, letting people know how to get connected, what's happening with this program, so that we can get people excited and get them interested in what we're doing. And then also, TLC's goal is to always look for partners and private people that would want to, again, maybe from a philanthropic perspective, engage in how do we help sustain these programs. So so we'll be developing a huge website and a marketing campaign. And if you want to go to the next slide, this is what we're building. This is what the Prince George's County Crisis Continuum looks like. The 9-8 call center with community crisis services, they're an integral part of this whole beginning. They're diverting the 911 to 988, because that gives telephonic help, and hopefully a lot of times we're finding that can help. And so they do the telephonic, but if that does not help, they will transfer the call. Right now, the behavioral health link is with the health department. We did this as an interim step because we wanted to be able to collect all this data. Dr. Somerville, Dr. Aljami, Dr. Powell, and Joe have been amazing partners in this, working out all the little twists and turns, tweaking the system. We've captured so much data that it's allowing us to know how to strategically move forward. But we have the behavioral health link. It then gets passed on to the mobile response team. The mobile response team then can also do follow-up. They can even take them to the stabilization centers if it's warranted. Again, this is all clinician-based. And sometimes we still will call, the police and EMS are still a very big part of this, but instead of going to the emergency room, hopefully we can take them the other pathways where they can get help outside of the emergency room. So this is where I'm hoping that all of us can focus and put our energy to make this happen, where we have that alternate route that can give, you know, the residents of Prince George's County the services they need, and provide it where the mental health services are in place to reduce the load on the police, EMS, fire, the hospitals, and navigating residents to the appropriate level of care. TLC is also going to try to help educate, you know, the community providers and organizations about how the system's going to be integrated into one another. We're working with all the partners to coordinate care and make sure that we're not duplicating services and that we're doing these warm handoffs so that there's not these gaps in care. So I just want to thank you again for giving me the opportunity to share with you, you know, this program. And I do see a couple questions. Okay, the question was, how are the peer supports doing that? With the mobile response team, the peer supports are part of that mobile response team. They're also helping with the behavioral health link at the health department. So we definitely, they're doing a great job. They will be also part of the, once we move the behavioral health link dispatch over to the mobile response team, iMind, because the reason we did this is because, again, we were trying to make sure as we're building the system, they're aligning with state regs and reimbursement rates. In order to get reimbursed for services, the dispatch has to be part of the mobile response team. So peers will be answering that that dispatch. So they will play a critical role in helping to navigate to the appropriate level of care. There was also a question in there about the age of that these services will be helping. The age for most of this is 18. It's for adults, but I can say we are also working right now with a group at the state that wants to do a pilot where we'll be looking at child and adolescents. So we will be looking at integrating that into this continuum. I do know, though, that iMind does currently have some resources for children and adolescents in their program. It's helpful. Check. Okay, thank you. Yeah, and you know, again, I think the more that we can compile all these resources and make connections, you know, please send anything to me. I love building teams and partnerships and bridges, because that's how we make better programs for people. So, and you know, I have been blessed and honored to be a part of this, but you know, I learned so much from Deborah tonight. So I want to thank you for allowing these kind of programs, because it takes a village, honestly, to make this work. 988 motor sense. Yes, I'm sorry, 988 is for any age. I'm sorry, I was talking about just the mobile response. And they do, I think Winnie is the chief operating officer, and they will do some adolescents, but I can get more information about that. I do apologize. I don't know the exact ages of that group that they're working on, but they do service the child and adolescent. And I just want to say thank you.
Well, we thank you. I thank you, Margaret, and appreciate you being here with the NAMI family. And what you've shared is very informative about something that's really important to our community. Just a couple of questions for you.
Sure.
The mobile crisis system, the staffing, what organization is that under? Is that Prince George's County government? Is that your organization? What organization is that under? Does that fall under?
And which organization are you talking about?
With the mobile crisis teams, who
The
are they?
mo,
Who do they work
actually,
for? Yeah.
it's, the mobile crisis teams are both. What we did is four of the teams are sponsored and funded by the HSCRC grant, and two of the teams are sponsored or funded by the county. And that was why we sort of transitioned to, iMind was always part of Crisis Mind. So they were like part of the Crisis Mind, which was CCSI and iMind. And then what we wanted to do for continuity purposes and seamless care is we just, basically iMind was always the mobile response team. And we just sort of went, but then iMind was the sole, they're the selected vendor for the county. So we didn't want to have it be split in two teams and have different processes. And, you know, if one got a call and one day it was iMind and the next day it was Crisis Mind, we wanted to make sure that we had unity with the mobile response team. So we basically just had the four teams that were used to be Crisis Mind just move over to iMind, because iMind was the clinical side of that anyway. So it just made it easier and seamless as a unit, as a functioning mobile response team. They're still, and then CCSI received the 988 funding. And so that was a lot of the telephonic, and I know we still talk with Erica quite a bit, and I know they have two full-time people that are working with the 988. I haven't gotten all the details as far as the scope of what they're doing, but so they're doing a lot of the telephonic de-escalation on the phone, because really we get a lot of calls. They get a lot of calls that don't dispatch to mobile response team. So they play a very important role as well.
Okay. So you talk about a mobile crisis unit. What is that made up of? Do you have a clinical manager? Do you have a case manager? Do you have a peer police officer? What is the makeup of that team?
So the mobile response team makeup is what we wanted, and this again, we were wanting continuity between like all of the teams. So basically it is made up of a licensed mental health professional. It is a technician or a peer. So they go out in twos at all times. And then above those teams, they have a clinical supervisor. And then above that, they have a operating or chief operating clinical person. So it's sort of like 3 levels. And right now, what we're working on is, so you always have 2-member teams that go out in the field and dispatch. Then above, then they have a supervisor on call, whichever shift it is. They have 2 different shift supervisors. And then if they need further, then there would be the chief clinical officer.
So if there's a safety issue,
Jamie, I'm going to interrupt here 1 minute.
Okay.
I apologize for the
Okay.
interruption, guys. We would like to note that we have Esha from Loomis Healthcare on here also. She wanted to jump on to speak with us and to contribute this evening. And so as we're going through questions, if you would like to share with us any of your experience or your perspective, we would love to hear from you. So thank you. I'm going to turn it back over to Jamie. Sorry for the interruption.
Do we have the other rep that was scheduled to be here? Why don't you give her some time? I didn't realize that.
No, she did
Yeah.
hop on. She doesn't have a presentation for us, but I would love for her
Yeah.
to be able to answer questions if we have any.
Okay.
Good. Hello, I'm here.
Hello, thank you. We really
Yeah.
appreciate you hopping on for us. So we
Not
do
a
have some
problem.
questions that are going back and forth, and we would love for you and Margaret and Deborah and Jamie to be able to answer and jump in if you feel like you have something you could add.
Absolutely.
Thank you.
Good evening, everybody. My name is Aisha Montague. I am the director of the behavioral health program for Luminous Health on both the doctors campus as well as the Anne Arundel campus. So we just wanted to share with you all about the services that are now open on the Prince George's County campus at Doctors. We have a brand new behavioral health pavilion. It was previously a the Magnolia skilled nursing facility, if anybody is familiar. And through a grant, through funding through the Prince George's County government, we have completely transformed that building into a behavioral health pavilion that includes outpatient services, as well as a 16-bed inpatient unit as well. So that you know that we have a psychiatric day program for adolescents and adults that will be opening in the next few weeks. We are just in the final stages of getting our state licensing for that program. We also have a outpatient behavioral health clinic that is currently open now for adolescents and adults, providing therapy services and medication management. We also have an urgent walk-in clinic for ages 4 and up. So any patient in need of non-life-threatening mental health services, they're able to walk in. Currently, we're 5 days a week for that service. So it's 8 to 5 for that. We will be expanding those hours in the coming months to 7 days a week, 12 hours a day. So we will be able to provide mental health evaluations, bridge prescriptions that are needed, as well as offering resources for referrals, either internally or to our community partners as well. Also on the ambulatory side, we also have a 8-bed residential substance abuse program that will be opening in December. It's a 3.5 level of service, so patients can get that level of service through us as well. They can be with us anywhere from 21 to 30 days, depending on the need and, of course, their insurance coverage. So patients will receive a minimum of 36 hours of intense therapy services through group and medication services if needed there. And our 16-bed inpatient unit will be opening in December as well. So a lot of things, we're transitioning all of these programs out and the rollout. So we're really excited. So that will be opening in December as well. However, current state right now, we are offering the services through the outpatient clinic. So we are receiving patients right now for outpatient mental health services, again, for adolescents and adults, as well as the walk-in clinic is open as of now as well. So patients 4 and up can receive services and assistance through us. So we're excited to be able to offer those services within the county and expand the services in the coming months. Not sure if everyone is aware also, but our emergency department on the Doctors campus is now doing emergency petitions. Previously, we were partnering with White Oak for behavioral health services, but we actually have a fully staffed behavioral health team on site at all times, 7 days a week in our emergency department there, consisting of mental health consultants as well as a psychiatric nurse practitioner offering services to patients in need there. So we are able to take emergency petitions now. We are coordinating care for inpatient services. It's been a great help to us to expand services. Everyone is familiar with the services that we offer in Anne Arundel County on the Anne Arundel Medical Center campus, but we've now expanded those expanded those services onto the Prince George's County side now. So we're excited and honored to be a part of the care team for the county. So again, we're open, free to take referrals. We are appreciative of the opportunity to be able to come and share with you all, and be able to spread the word to hopefully get the community the support that they need.
We have a couple of quick questions for you. They want to know, are the EPs only for adults or for adolescents too?
Adults and adolescents, current state. The name of the program you're describing. So it's actually on the Luminous Healthcare website. So all of our services are on the website for Luminous Health. So it's a pretty easy, so luminoushealth.org. It's a pretty easy website to navigate. If you go to the website and under behavioral health services, all of our programs are listed. Also, I am personally conducting, I have some time allotted for tours of the building while we are still in the early stages of opening, before everything is up and running, so we can allot some time for you to come and, view the facility. We can, definitely get a tour. You can have get a good vision of the services and meet some of the providers as well.
One other question we missed was, how do people get into the 16-bed space?
Into the 16-bed space. So that is through the emergency department, or through our emergency department or other emergency departments. So these, the referrals are not only for internal referrals. So it will be very much like our McNew facility in Annapolis. So the same way, for admissions, contact us if you have a patient in need, but it must be through an emergency department or through one of our approved psychiatric day programs. So I'm actually going to put my email in the chat for everybody. So if anybody is interested in a tour or reaching out to me for additional information, I am happy to set that up. We have a couple of months, so December will come faster than we know. So my goal is to get as many of our community partners through the space so you can kind of see it, get familiarized with it, get comfortable with it, with the services that we're offering, so that we can be of assistance to you in the future.
Thank you. I do know that we had a question, I think from back when Deborah was speaking, and when we transitioned into Margaret. Somebody was asking about, what can a person expect when they make a 988 call? Can anybody speak to that?
I can I know when we've been talking with not only CCSI, but also at the state level, the goal there is to have call specialists that can help, that are trained to help de-escalate any situation that they can on the phone, and get some, and like I said, I know at CCSI, Erica is a clinician, and so I know that depending on who's taking those calls, but I know there are call specialists that have been specifically trained for different reasons. So I know they are supposed to be able to hopefully navigate people to the appropriate level of care that they need, de-escalate the situation via telephonic, and make that determination as to sort of whether they need that mobile response, whether they need from the mobile response team, whether they need EMS or fire, or police. So they're sort of that gateway, and we're trying to make sure that 988 gets out there because it's easy to remember. So we're helping to promote that as well as part of the crisis continuum.
Thank you. I think that we have a question for about Loomis Health. They said, we don't see any behavioral health information for adolescents on loomishealth.org. Is there a specific place they need to look for treatment for adolescents?
Yeah, it should be included there under behavioral health services. I would have to take a look. The website literally was just updated on Friday. We had not gone public with any of this information just yet because we with only the one service open on the doctor's campus. So I would need to take a look, Ms. Dixon, and kind of get back to you on that one, because we definitely have adolescent programs current state. So adolescents are incorporated in our psychiatric day program. We also have providers that are dedicated for adolescents and peds with therapy services and medication management. We have pediatric psych NPs, as well as peds and adolescents psychiatrists, as well as therapists on both campuses.
Thank you.
Christina, there's a question from Adrian about the residential rehab programs
Okay.
and where they located. It is the state of Maryland has a form, and the form is used across the state, but there is a local behavioral health authority in Prince George's County where the form would go. So there are some providers, and Gina Greenhood is on the call, that have housing associated with their mental health services. So they are connected. Individual would have to meet certain criteria, fill out the application. They would have to have a clinician to sign it, indicating what their diagnosis is. That application would be sent to Marguerite Parker, who is the adult coordinator. Then it is reviewed to determine if they meet the criteria. And then if they're mental health providers, for instance, People Encouraging People is one, they're the acting. We have new ones now. There's Family Service Foundation that I'm aware of. There's Vesta and probably a few others in the county. And depending on whether or not they have openings, and if the individuals who's applying meets the criteria and wants to get both their housing and mental health services through the providers, then that's kind of the process. There is a bumping order. If someone is coming from the state hospital or from the jail, they get priority over someone who's in the community in terms of placement. So it is a process. And of course, that's one of the gaps I didn't mention, but housing is a gap for individuals with mental health conditions. And we did address the peers. That's another one. So the peer support, I believe, is very crucial in terms, and I think all of the mental health providers in the county need to have a peer to engage with our loved ones, as well as family peer specialists. I mean, you know, everyone has some family that supports the individual. So I hope that answered your question, Adrian.
Were there any questions that we missed before we wrap up? We did want to share, if there are questions, please put them in the chat. While you're doing that, we did want to share with you, we sent out a recent survey. I think most of you should have gotten it, about the use of crisis response services in PG County and personal experience. We wanted to try to get an idea of what your experience had been. Overall, we just wanted to report a couple of things of what we learned from this. About 50% of the people who responded had used crisis services in the last year. And of the people who responded that they had used them, they said that 70% of them did end up having law enforcement involvement in their experience, and that led to other issues and problems within their experience. They did feel like our responses were about 50-50 as to whether or not people felt like they were receiving the help that they were needing, or whether it was easy for them to receive the help that they were needing. Overall, they said that approximately when those that felt like didn't get the help that they needed, it tended to be after they were discharged from the hospital, and they felt like I felt lost in that gap. That was what we were finding, which met with Deborah's presentation today, that's where people were finding the difficulty in managing crisis. It wasn't so much in the immediate crisis, it was that gap into treatment. And we just wanted to share that quick overview, and we appreciate everybody who did respond to that. We have that information to share, and I'm going to turn the time back over to Jamie now, since we didn't get any questions while I was talking, and I'll let him close us up. Thank you.
Well, we're very thankful to our panel members, and it's certainly encouraging to me as a NAMI board member that we got stakeholders here on the phone that are working very hard. Margaret and Este, I hope I got that right. If I did, please forgive me.
Aisha.
If I did not, Yeah, thank you. Very good. I was trying. So I am grateful for both of you tonight. And Deborah, you know how I feel about you already. That's no secret. So and I certainly want to be here for anyone. You know, if for a resource or any kind of partnerships that I could be a part of. And this is all just very encouraging to me as a person who is also a consumer and an advocate and a longtime resident of Prince George's County. So I'm very thankful for your time and being able to take on some difficult challenges. And even for me, you know, I think I got carried away at one point. So appreciate your patience, Margaret. And just for all of the participants, we're grateful to have you here on the meeting, on the call with us, and certainly hope that you got something that you can take home with you, some encouragement, some resources, and we're hopeful that that you had a good evening with us. And I believe that's all we have for now.
Well, and I would like to just say thank you to everyone, and please, if there's anything that we can do to help and connect, you know, please reach out to me and let me know how we can do that. Because like I was saying with the presentation, and I know one of those survey questions talked about law enforcement. I can tell you, being on the work group and the senior leadership, it is amazing the commitment that's there. You know, it's just a new arena, it's a new space, you know, for everyone. But I do want to let everybody know that I was so amazed at the amount of commitment and time and effort that police, fire, and EMS is really trying to make this a good system, and they want the help, you know. So I just wanted to say that, because sometimes I just think when I hear that sometimes, you know, law enforcement needs to be involved, and I think we need, but how do we work together to make it a good experience for everybody?
Thank you.
Jamie, I forgot to say, I dropped an evaluation survey link in the chat. Please take just a few minutes. It should only take you 3 to 5 minutes to fill it out, but it's very helpful for us on the flip side. So thank you again so very much.
And I just want to say thank you, everyone, for hearing my story. It's maybe one that's not too inspiring, but it is one that fuels me to do what I'm doing, because it's not just for my loved one, it's for all of our loved ones. We know the statistics is 1 in 5. You know somebody you are individual living with, or you will eventually, or you may. I won't say you will, you may. So it's just important for us to be able to help our loved ones stay stable in the community. The crisis is not over when they leave out. It's just starting all over again without a tool. And a strategy, we always told, copy and paste that link for those surveys. And then when you get off the call, you can still take it.
Thank you for that plug, Deborah.
You're welcome.
Thank you, everybody, and have a good night.
Good night.
Bye-bye.
Take care, everyone.
Bye-bye.